This is a 62-year-old otherwise healthy woman who presents with evidence of lung nodules on a routine chest x-ray. Additional imaging included PET scanning, which found evidence of lesions in the adrenal gland. This patient underwent bronchoscopy with fine needle aspiration, which identified adenocarcinoma, and additional molecular testing identified an ALK rearrangement. This patient was felt to be a good candidate for therapy, had an ECOG performance status of 1, and so is looking at a standard option here up front as their first line of therapy. This patient is typical of someone we would see in our clinic, either in the hospital as a consult or as a new patient in our clinic. There's a couple of things just to point out in the workup of these patients. So this particular patient had a bronchoscopy and fine needle aspiration. That is very common. What's uncommon about that scenario is to get the ALK results. So FNAs, unfortunately, frequently don't provide enough information to get ALK testing performed at a lot of community hospitals. And so my only kind of, I guess, teaching point for this is that don't stop there. If you just found out this woman had lung cancer, but you didn't have enough testing to do ALK, I would say this patient needs a second biopsy because you wouldn't want to deny her a chance to get an effective oral first-line therapy. The other thing I'd mention in the workup here is brain imaging. ALK rearranged lung cancers are frequently associated with metastases to the brain. It's a part of normal lung cancer workup for anybody with advanced disease, but this patient especially needs brain imaging in the form of an MRI ideally. PET scanning will not adequately address that. This is a patient that we would talk about giving upfront oral tyrosine kinase inhibitor therapy. That this is not a patient we would give chemotherapy to. We used to, but now we know better that an oral ALK inhibitor is going to outperform, be better than chemotherapy in the first-line setting. We now have 2 large randomized trials that have shown that, have proven that. And so for this patient, we would offer them that therapy. We get kind of excited when we identify these alterations in the initial evaluation of patients, primarily because the therapies are so effective and it's so gratifying to be able to give somebody an effective therapy up front. And the prevalence of ALK rearrangements is low enough that you don't see this that routinely, certainly in the community setting where you're seeing a lot of different kinds of malignancies. About 4 to 6% of patients will have this kind of lung cancer. We know that patients will generally fit a certain phenotype or clinical picture, so tend to be non-smokers, tend to be a little bit younger, but that doesn't mean you can't have an 85-year-old patient with an ALK rearranged lung cancer or even a smoker. I've had that very patient in my clinic. These patients tend to do very well, and that's because the therapies are so effective. So these patients tend to be at the upper end of the bell curve, so to speak, in terms of responding to therapy, having a prolonged what's called progression-free survival, so living without their cancer growing, and then overall survival. And they also do well with chemotherapy as later lines of care. One thing I will say, though, is patients with ALK rearranged lung cancers have aggressive cancer, so not to be dismissed as an indolent situation and you don't have to do anything quickly. I mean, these cancers can grow quickly, can progress quickly, and can be life-threatening for patients in a very quick way. So identifying the cancer, finding the right therapy and getting it started is really paramount.